and happy holidays. Today is the 16th, and this is the Senate Committee on Health and the Select Committee on Mental Health, the Mental Health Parity and Access Oversight hearing that we're going to have today. So, you know, with the implementation of the Affordable Care Act, we have mental health as being one of the 10 essential health benefits. I've always, advocated access, especially to the most vulnerable communities. If you look at what's gone on with homelessness, to drug abuse, to, suicides, to mass shootings, I mean, there's a lot of mental health that's kind of tied into that as well. I've always had the concern that we have mental health over here, but we need to figure out how we're going to tie mental health to physical health. I know in LA County, Dr. Katz is looking at, they're going to do some work with bringing in the mental health and having been part of physical health. And the other concern I have is access, more importantly, access to the most vulnerable communities to mental health services. And so this hearing today is going to be kind of the beginning of that conversation. Hopefully we can continue it. And I guess the questions that we're going to be asking today, the policy questions, do we have enough mental health providers? Are they in the right areas? Are we getting the care that we need to the right populations? How are we going to integrate that mental health into physical health? And more importantly, how are we going to measure outcomes? And how are we going to be holding the providers accountable for the care? How are we going to be using innovative ways, whether it's telehealth, et cetera, to find out if that's going to be the case with regard to the ability for patients to get mental health and mental health services. So with that, I can open it up to any of my colleagues who might be interested to see if they want to make any opening statements. I don't know if Senator Bell or Senator Pan at all would like to make a comment.
Hello. I'd like to thank everybody for attending the meeting. I'm Jim Bell. I'm chairman of the Select Committee on Mental Health for the State Senate. And we're happy to be here today to talk about that subject. It's very important. We're going to hear from consumers in a few minutes, others. I'd like to share just a few words. The purpose of the hearing today is to receive an update also regarding the status of federal and state parity compliance in California. Now, the fight for mental health access and parity is a personal one for me. I often think about many families I've met over the years who have been denied proper mental health treatment. The Department of Managed Care is using some new positions. Thank you. And new positions that we successfully lobbied for in 2014, staff positions we put in the budget to implement and have resources to implement our parity laws. But it's not enough to have the laws on paper if we do not enforce them. And so for the first time, health insurers are now going to be required to submit documented evidence providing they're complying with the law. Based on the review of the plans, we're going to shift away from sort of an honor system to a one where they're being checked over on a systematic way. And beginning in 2016, the department will survey plans to ensure they have corrected any deficiencies identified in the review that take place. Systematic reviews of all the health plans. It's going to be very important. It's very important that we all monitor that and watch over that as a legislator to see if it works, if we have to make any changes or improvements to make sure that access is not falling below the level that we have as a standard of parity. We'll also hear today from consumers, health plans and providers on their perspective on the implementation of mental health parity, the network adequacy, as Senator Hernandez indicated, and timely access to service. I heard a lot of people in my district talk about the issue of timely access to service. With the Affordable Care Act pretty much guaranteeing that everybody's supposed to have health care, right? I think we have this, we have a workforce shortage, and we need to look at that in a real sense and see if we can increase access by increasing the workforce in our healthcare industries and providers. Now, I plan to use this information and recommendations I hear today to work with my Senate colleagues that are interested to make necessary changes to improve access to mental health services and ensure that mental health parity is fully implemented in the state of California. And thank you, Senator.
Anybody else want to make a comment?
Well, thank you so very much. I want to thank both Senator Hernandez and Senator Bell for your leadership in this issue and calling this hearing together. As a pediatrician, I actually clinically focused on children who had behavioral issues. I'm a general pediatrician, but I did 2 years of fellowship training in behavior and development. And I know that I've worked with many families who've struggled to try to get mental health services, developmental services for their children. I also have seen situations where because of having difficulty accessing qualified providers, people have had sufficient training where they've been on inappropriate treatments as well. And I know this is something that the legislature here has had to deal with as well this past year and will continue to deal with. So I think as we move forward, someone who's also done research on workforce and looking at how do we get quality access to care, we have to keep in mind the quality aspect. And also how do we be sure, thinking about appropriate delivery systems to ensure people actually have access to quality care, particularly patients and their families with mental health issues. So I really appreciate that we're having this hearing today and looking forward to an ongoing conversation about how to ensure access to quality care and can we think about ways we can structure the delivery system in a way given to be sure that all families can have access to the care that their loved ones need in mental health. And I also point out the brain is part of the body. So let's think about how we can bring things together. Thank you.
Thank you. Any other members like to make any opening remarks? Seeing that. Oh, cool.
Mr. Chair, thank you. I think it's really easy to make promises if you have no intention of delivering on those promises. And one of the things that I am very grateful is my colleagues being here today to make sure that we deliver on the promises that we've made to our constituents and to all of Californians. Thank you.
Okay, we're going to go and get started. We have the first group of presenters. We have from some consumer experiences. I'd like to call up Patricia Wenzel. Now, after that, come on up, Patricia. We have going to have 4 family members from the family of Barbara Reagan after that. So there's only 4 seats. I believe there's 4 more presenters after that. So maybe after you speak, if you can go sit down, let the next family come up, speak, and then be prepared to come up because we will be asking questions, and then we'll move on to the next panel after that. But welcome, and please proceed.
Thank you. My name is Patricia Wenzel. I have bipolar I disorder and have been psychiatrically hospitalized 5 times in the past 4 years. I'm also the parent of 3 now adult special needs children. 2 have serious medical conditions. They have also had mental health challenges which have required psychiatric hospitalizations. In the community, I wear several volunteer hats. Facilitator of a support group for adults with mental illness offered by the local chapter of the National Alliance on Mental Illness, better known as NAMI. I answer the peer-operated Mental Health America resource and referral warm line 3 days a week, and I sit on the Services Committee and the Evaluation Advisory Group of the Mental Health Services Oversight and Accountability Commission. I am here today at the behest of NAMI, California. Unlike many people with severe mental illness who must rely on Medi-Cal because they are too sick to work, my family's coverage has always been through my spouse's CalPERS benefits. We have had managed care commercial plans in Sacramento County, including Blue Shield, HealthNet, and Kaiser. I will focus on our experiences as members of Blue Shield HMO and HealthNet. Blue Shield contracts mental health services out to a behavioral health services organization here in Sacramento County that has been a company named Magellan. HealthNet has its own mental health subsidiary, MHN, which handles authorizations and denials for HealthNet. When we have sought mental health care, our point of contact has been MHN or Magellan, not the insurance company per se. So when I refer to the insurance in my comments, I'm referring to MHN or Magellan. It can be difficult to make comparisons between mental and medical health care. My framework for assessing parity focuses on 3 basic questions. Will the same general standard of medical necessity be applied? Will I have access to a network of qualified professionals, including specialists with experience treating my condition? Will I and my treating professionals have access to a range of evidence-based treatments that can be deployed to prevent and treat crisis and rehabilitate me following a crisis? Using this framework, we can ask the question, do we have mental health parity? Based on my experiences and the experiences of the people I have heard from in support groups and on the warm line, the answer is no. We still have a long way to go. Let's look at the standard of medical necessity. The standard applied to mental health services is often a much higher one than the standard applied to receive a similar level of medical care, in my experience. One of my sons has severe Crohn's disease. His medical hospitalizations are not difficult to get authorized. When he has significant symptoms, which are almost certain to worsen, become life-threatening if left untreated, he is hospitalized. Is that the standard applied when I need psychiatric hospitalization? No, it is not. Regardless of the presence of severe symptoms and the likelihood that they will worsen, I cannot get inpatient care and may not be able to get intensive outpatient care. The recommendation of my outpatient psychiatrist and treating therapist appear to carry no weight. My own request to be admitted voluntarily due to severe symptoms has been worthless. Unless I have a concrete plan to kill myself within a matter of hours or have been completely incapacitated, I am not considered sick enough to merit hospitalization. This is like telling someone with Crohn's who is having 10 to 12 bloody stools a day that they have to wait for it to get to 24 bloody stools a day with the need for transfusions before you will admit them for inpatient care. It is cruel and puts lives at risk, and there is no appeal process as far as I know. As an inpatient, I became very familiar with the phrase, "we'll see what the insurance says," when I asked about the length of my stay. The power to determine the length of my stay seemed to be in the hands of the insurance company's utilization review nurse, MHN or Magellan, not my doctor. It was also clear that the doctors were under tremendous pressure to treat patients with the maximum medical interventions, i.e., the maximum number of drugs at the highest possible doses, regardless of the wisdom of doing so. While inpatient, I was coerced into taking high doses of drugs with severe side effects. I believe the doctor's goal was to discharge me quickly, regardless of the relative safety of starting me on such high doses. There is no appeal process for discharges that I was ever told about. On to the next 2 questions. Will I have access to treating professionals, and will I have access to evidence-based treatments? The barriers here are masked by lengthy provider lists of adult psychiatrists, poorly qualified therapists, and exacerbated by an arbitrary rule about what is a reasonable distance to travel, inherited from the medical side. There is the appearance of access to care, but in our experience, specialized populations like adolescents and children do not, in fact, have access to qualified care delivered in an appropriate way. There are very few child psychiatrists available. Many children and adolescents are treated by generalists who may not have the training to accurately diagnose and safely treat children. In-network therapists only have to mark the right box on a form to claim qualification to treat a specialized population such as adolescents. Some therapists check every one of the 25+ boxes, schizophrenia to anorexia, preschoolers to geriatric patients and first responders. My suicidal and rageful adolescent son received the traditional standard of care from in-network therapists who said they treated adolescents, but in fact had little to no experience. He ended up hospitalized again and again, and we had to travel long distances to see these poorly qualified therapists trying to treat someone who was not an adult with an adult-oriented treatment model. When I tried to get a single case agreement with a highly qualified therapist close to our home, it was denied because there were supposedly in-network therapists, the ones who had checked the adolescent box, within 30 miles of our home. Think driving from South Sacramento to Folsom or Davis with a potentially violent, delusional adolescent male in your car. Once again, there was no formal denial and no apparent appeal process. The adult model of in-office visits and hospitalization is used for children and adolescents with severe illness, despite the fact that intensive wraparound services is a successful, evidence-based model for this population. But those services are not covered by commercial insurance plans. My son only got those services through a grant-funded program when he was jailed for assaulting me. But I am lucky. I live in Sacramento County. We have a handful of the 57 beds dedicated to children statewide, as well as inpatient beds for both adolescents and adults. We have 27 beds per 100,000 people, about half the number of beds experts say we should have. 45% of California counties have no psychiatric inpatient beds at all. 79% have no child or adolescent beds. Since intensive outpatient services are usually run by a psychiatric hospital, those same counties have no intensive outpatient services either. What do we need to move us toward parity? Here are some of my ideas. Increase transparency in the denial process for mental health admissions, discharges, and other mental health services, such as single case agreements and options for timely appeal. Facilitate and motivate doctors and nurse practitioners to enter the field of psychiatry and to practice in underserved communities. The Song Brown program could be a model for this. Increased efforts to find and fund alternatives to hospitalizations for all ages. We need to focus on prevention and early intervention as well as crisis treatment. The construction of more psychiatric hospitals, especially beds for children and adolescents, and for existing medical hospitals in rural areas to add psychiatric beds would help. Access to a full range of evidence-based treatments for children and adolescents with severe mental illness, specifically wraparound services. They are not little adults. Adult treatment models do not work for them. Behavioral health service organizations like Magellan and MHN should be verifying the integrity of their provider lists. Are therapists taking new patients? Are they even returning calls? Are they really qualified to treat all the conditions and special populations they say they are qualified and willing to treat? It is not humanly possible to be qualified to treat every age group from toddler to elder and all 25+ conditions the therapists have to choose from. Yet there are therapists on the list who have checked every single box. If they're already taking these kinds of continuous quality improvement measures, it isn't apparent to me as a consumer. I think the 30-mile rule is too broad. It may be reasonable for medical providers whom you see infrequently. For mental health consumers, it has the effect of greatly limiting access to care for many people. 15 miles is a more reasonable standard, in my opinion, or there needs to be a relaxed standard for single case agreements in the case of hardship like reliance on public transportation, a lack of well-qualified providers, or extenuating circumstances such as patients with severe anxiety when traveling in a car who are actively and unpredictably delusional. And finally, encourage the move toward integrated care. Do we have mental health parity? My answer is no. Things are better, but we still have a long way to go. I believe we can get there if we continue to work together to achieve that goal. Thank you for the opportunity to speak to you today.
Thank you very much. And if you can be close by so that when we prepare to ask questions and we can, anyone would like to ask them of you. So we're going to now move on to the family of Barbara Reagan. I believe we have Dennis Cafaro, Vicky Tugenza, Michael Reagan, and Patrick Reagan as well. I don't know if they're all going to be coming up or not. Yeah. Well, good afternoon, and in any order, whoever would like to go first, please state your name and proceed, and welcome.
Denise Caparo, and I will be speaking for our family today. So we want to thank you and the members of the Senate Health Committee and Select Committee on Mental Health for inviting us today to this oversight hearing of our mother's experience. Well, I'm sorry, to hear of our mother's experience. On July 5th of this year, we were told by a Santa Rosa police officer that our mother, Barbara Reagan, had gone to the 3rd floor of the parking structure next to the Santa Rosa Kaiser emergency room, dressed in her nightgown, robe, slippers, and had jumped to her death. We were in utter shock. It made no sense. The mother we knew, the woman she was, would never do this. It was all too evident and overwhelming that something had gone very wrong. Our father said that she had been fine prior to an increase of medication 5 weeks before, but within a couple of weeks, there was something very wrong. He showed us the multiple medications she had been prescribed over the past 5 weeks. He said that she was trying to get help from Kaiser, but Kaiser was not helping her. She was not able to get an appointment, and that her care was being managed over the phone. He said he had been concerned because she had been continuing to get worse over the weeks, not better. He said the last time she had an appointment with a mental health doctor was over a year ago. He said that just 2 weeks before, she was so scared by how bad she was feeling that she insisted he take her to the emergency room immediately so she can get help. We thought, why was she not being seen? Trying to make sense of all of this, we looked online and became aware of the gross problems that had been reported about Kaiser's mental health department. We read that in September of 2014, Kaiser paid a $4 million fine that was levied by the California Department of Managed Health Care for violations of state regulations. There were many reports of Kaiser's delays in appointment time. We read that medical providers under the state's mental health parity law are to give their members non-urgent appointments within 10 days and of serious concerns, an appointment within 48 hours. We're here today to state that these problems happened to our mother, and we feel that they are still happening to other people today. A little bit about our mother, so since she's not here to speak. Our mother, Barbara Reagan, was 83 years old, was married for 62 years with 5 children, 12 grandchildren, and 13 great-grandchildren. She was a mother of the 50s, a stay-at-home mom, and when she was in her 40s, she went back to school to receive it and received a certificate in medical transcribing and started working. She worked for Kaiser for 15 years. She was a Kaiser member for almost 40 years. When she and my father moved to Santa Rosa, she was receiving services at the Santa Rosa Kaiser. As I said, she was 83 years old, but really she was 83 years young. She and my father, Denny Reagan, who's 87, lived together in Oakmont, Santa Rosa. They were living completely independently. Up until a few weeks before she passed, she was driving, going to the community gym, swimming, going out with her friends, doing weekly shopping, gardening, housekeeping. And even on May 9th, we took her out for the afternoon for Mother's Day, and she was fine. Nothing like what our father said like what our father said or what her medical records reported she was experiencing just a month later. 20 years earlier, my mother did experience a significant depression, but she never expressed any thoughts of suicide to her family, friends, or from any statements in her medical records, nor had she ever attempted suicide. She was seen and treated over the years by Dr. Kagan, a psychiatrist at the Santa Rosa Kaiser, and she was proactive, continuing to get mental health services, and stayed on an antidepressant to help her. We retained and read our mother's medical records from Kaiser. Her records show that in the past 5 years, she has had 4 office visits in the mental health department, 2 in 2011, 1 in 2013, and her last office appointment where she had one-on-one in-person services was March of 2014. She also had 5 scheduled telephone appointments. On her scheduled March 2015 scheduled telephone appointment, she told her doctor, Dr. Kagan, that the antidepressant she had been taking for many years, Prozac, was not helping her as it had. Dr. Kagan made a change of medication to Zoloft. Her next scheduled appointment was May 28th. On her scheduled May 28th telephone appointment, her mother stated that the new medication Zoloft was not working well enough. Dr. Kagan instructions were to increase the dose and advised her to give the Zoloft the 4 to 6 weeks to work. Dr. Kagan even put into her notes, patient well known to me. June 12th, 2 weeks later, at 12:14 p.m., after she followed Dr. Kagan's directions and had increased the Zoloft, my mother called and left a message to the doctor, and we do have her medical records that this is what it said, in quotes. She's not doing well at all. Asked if she can take more of her medication. Says it is serious and needs someone to help her today. She stated that she feels too horrible to go out, has lost 10 pounds, and it was not like this until she started the increase of Zoloft. No one called her back. So 3 days later, on June 15th, she told my father to get her to the emergency room immediately. At 10 o'clock that morning, she was in the ER stating, and again, this is from her records, "I feel like I want to die. This is worse than I felt many years ago with depression." Well, now she was in a deep depression and having high anxiety after the increase of Zoloft. She was not experiencing these severe feelings on May 28th before the increase of the Zoloft. The emergency room, she was sent from the emergency room up to the mental health department, where she was instructed to stop the Zoloft, and a change was made to Lexapro. She was told that she would be given an appointment date to be seen by a psychiatrist. Well, she did receive an appointment date, a card in the mail, with an appointment for August 25th, 2015, which was over 2 months away. Then 2 weeks, 3 days later, after starting the new medication on July 2nd, at 2:27, again looking at her medical records, it states that my mother called and talked to a nurse, and I'll quote what is written in her medical records. This is what my mother's is on her records. "Medication Lexapro is not working, and it's making it worse. She said that she is getting worse and feeling more depressed for about the last 5 days. She said is having thoughts of suicide. Nurse spoke about going to the emergency room if suicidal thoughts is serious with intent and plan. Our mother stated that she was doubling the dose of Ativan because she wasn't getting any help from her prescribed dose. The nurse wrote in the records, last seen by Dr. Kagan, 5/23/14, and next visit, 8/25/15. The nurse did make a note that she needed medical approval, and she even added, if response is after 3, please call patient as there is no nurse in the office. So at 3:37, a doctor did call my mother back, our mother back. Dr. Hoffman calls our mother Our mother reports feeling more depressed and anxious after starting Lexapro. The anxiety has worsened as the dose has increased. She said that she's having thoughts of suicide, but she did deny desire to die or a plan or an intent. She verbalized understanding and agreed to go to the emergency room should she start to feel she would act on thoughts of self-harm. The doctor tells her to stop the Lexapro and to go back on Prozac, the medication that she was taken off of 3 months prior because it wasn't helping her. Our father said when she got off the phone, she turned to him and said, "Denny, what am I going to do? They're not helping me. I can't find help. The medication is not helping. It's making me worse. I can't wait that long to be seen." Our father has repeated these statements to us over and over again. On July 5th, 3 days later, our mother did go to the Kaiser emergency room, but it was to the third floor parking structure, and she jumped to her death. There was an article written about our mother in both the Santa Rosa Press-Democrat and the LA Times. These are just a few statements Dr. Mason Turner, Kaiser's Director of Outpatient Services for Regional Mental Health, made in these articles. One, that she received a tremendous amount of care in the weeks before her death. Two, the care Miss Reagan was receiving was exceptional care. And the third, a few days before her suicide, she was evaluated over the phone by a psychiatrist. Well, if the care she was given was a tremendous amount or exceptional care, and an evaluation is a few minutes over the phone with a doctor that she made the phone call to, there is a real problem. I read an article about the problems happening within the Kaiser Mental Health Department, and it said, in quotes, "It's a small number of people who will commit suicide because they're not receiving that individual time. The vast majority will continue to suffer with their mental health symptoms." Well, our mother was one of those small numbers. And it is almost unbearable to all of us to know how much she was suffering and the pain she was feeling those last weeks and days of her life to bring her to the point of taking her own life. It's a tragedy that her husband, children, grandchildren, great-grandchildren have to live with for the rest of our lives. Our mother, Barbara Reagan, was trying to hold on to life. She was asking and she was seeking for help. Our mother did leave us a note. It reads, "My children, I love you so." I'm sorry. "My children, I love you all so very much. Mom, Denny, I love you, Barbara." Her last sentence, the last words she left to us in this note is, "I couldn't stand the pain." The last word she wrote, pain. She couldn't stand the pain. It helps us greatly and gives us comfort that she left us with love in her heart. She left us. But oh, how sad and heartbreaking the unbearable pain she was experiencing the last days and moments of her life. For us, it is a pain that we hope and we pray that no other person or their family will have to go through. And that is why we are speaking out. We want this to stop. We want people to get the care and services that they need. The healthcare providers are profiting greatly from the monies they receive from their members. These members expect and deserve these services that are regulated and mandated by state and federal government for members of healthcare to receive. Now we are asking and seeking help from you, all of you. Please, please help us. Help the people of California that elected you to office, the Californians that trust you. We need your help. Please scrutinize and oversee these providers to give their members the services regulated by law. Again, please stop this from happening to anyone else and their families. Thank you again for giving us the opportunity to speak out today.
Thank you. Anybody else will be speaking or have any other comments from your family? Okay, thank you. So we will now open up to questions from any of the members. Was there any questions from any of the members? If we can bring up Patricia again.
I need a question.
Yeah, Senator Bell had a question.
I'm sorry for your loss, okay, and express our condolences to your father.
Yes.
In what you said, your mother was prescribed some medications, and it sounded like, when did the first medication start?
The Prozac, I think about 20 years ago, when she had gone through into a depression. I mean, again, she didn't want to feel like that again. She wanted out of it, and she wanted to feel better. Prozac is what I had known her to have taken all those years. We have her medical records back to 2006, and it was Prozac. It wasn't until recently that I think she wasn't feeling that it was, again, we could only assume from what her medical records state, and we knew she went on to a change. It probably wasn't helping her as well as she thought it would be. That's why in March of 2015 is, and it was right there, March of 2015 is at a scheduled telephone appointment with her doctor. She said that it wasn't helping. And so that's when the doctor said, why don't you, let's go off the Prozac, go on to Zoloft. So she started this Zoloft in March.
Oh, they didn't, they just did that over the phone?
All over the phone. Her last appointment was it March of 2014? So March of 2015, there was a scheduled telephone appointment, according to her records, where my mother stated that the Zoloft wasn't helping her as well. So the doctor said, let's change from Zoloft, I'm sorry, Prozac. It had been Prozac that she had been on, and go on to Zoloft. And it sounds like she did okay on the Zoloft from March. And
Zoloft and started the Prozac.
I'm sure they probably weaned off, you know how you,
Yeah, there was a
I'm sure he said taper off the phase in and phase out. We're going to phase out of Prozac. We'll start you on Zoloft, phase in. And it sounds like the 2 months she did okay, because it wasn't until May that my mother said that it wasn't helping her as much. And then the increase started. At that appointment, the doctor said, go up 25 milligrams for a week. If you tolerate it, go up another 25 milligrams, as I think is what it stated.
Was that a telephone appointment?
That was telephone.
Okay.
Everything was telephone. The only time she saw a doctor, so the last scheduled appointment was March of 2014. She did see a doctor on June of 2014. Did I say? Her last appointment was where she walked, she had a scheduled appointment, was March of 2014. Her care was all over the phone after that, except for her ER visit. Her ER visit, when she walked in, they sent her upstairs, but I wouldn't consider that a appointment. That is, look at me, something's very wrong. So with that increase, once that...
The Zoloft, if I can get this correct, the Prozac, sir, she said, okay, we need something different, so they go to the Zoloft over the phone. And her last appointment with the doctor was 2014 and a year before. And then in May, they upped the Zoloft dose. And then when did she go to
2 weeks later.
the Lexapro? When did that happen?
I'm sorry, when she, but 2 weeks later, when she ended up in the emergency room in high anxiety, thoughts of suicide,
Zoloft, and then they tried to up it, and then she went in the
that
emergency.
increase of dose must have gotten, I'm not a doctor, but and I've seen it happen before, an increase of dose can,
Okay, the question I have
havoc.
is, was there
It's
a reason why they didn't have her come in for a full appointment or anything?
that would be our question. They said they'd give her an appointment, and she did get one, August 28th.
It went basically in 3 months to 3 different drugs without an appointment, is what you're saying.
They really went, it was, she started the new in March. She started Zoloft. And then at the end of May is when she said it wasn't helping as much as she felt it should. So the doctor did the increase. 2 weeks later is when she went on to the Lexapro. And then 2 weeks later, they said, oh, go back on to your Prozac that you had taken years before.
Oh, okay.
Well, if I may make a statement, I just feel that we're not equipped to handle it, anything other than the general prescriptions. I mean, they're good at dispensing medications, but when these people seem to have the issues, we've had contact with many people that have talked to us that have been similar situations. And it seems like they're just not equipped to handle these emergency situations that arise when they need to bring somebody in. They're just dropping the ball on these types of things. And for some reason,